Good morning, everybody. On behalf of the Cardiovascular Division at the University of Miami Health Systems, I wanted to welcome you all today to our Topics in Cardiology Grand Rounds. So in anticipation of our transition to high sensitivity troponins at the University of Miami Hospital and Clinics and UHealth Towers and throughout the University of Miami Health System, today we will be discussing the role and benefits of high sensitivity troponin in the evaluation of chest pain, suspected acute coronary syndromes, and myocardial infarction. So first of all, before we start, I would like to acknowledge that we have no conflicts of interest as pertain to this lecture, and that this has been a truly multidisciplinary endeavor and would not have been possible without the help and engagement of various different specialties, divisions, and departments throughout the university and health systems. Dr. Wagner from the Department of Pathology has been instrumental and certainly spearheaded the efforts, and his team, including Paola Pagan, has been instrumental to put all the pieces in place, protocolize the laboratory aspects of the transition, and the anticipated changes that will be happening. Dr. David Lang from Emergency Medicine has provided valuable leadership, directorship, and insights leading us to our implementation. And the ED, in fact, will be one of the primary sites using troponins for assessment, risk stratification, and triage decision-making. We've also had a combined effort within our own division of cardiovascular medicine to bring this into action. And as you can imagine, there's a significant workload on the back end, behind the curtains, so to speak, to pull this off. So while some of the development continues to be put into place, I wanted to acknowledge and take our hats off to the IT team and EPIC team that have put this in place, led by Dr. Marissa Suarez, which have worked hard to put in place logistical pieces, including EPIC order sets, alerts, etc., and all the work that is necessary to make this possible and will ultimately make it successful. So finally, the last piece of the team will be you all, the frontline providers who are in attendance today, the physicians, attendings, fellows, residents alike, as well as the advanced practitioners, the PAs, the nurses, techs, and students, and all the ancillary staff that will help us in the transition. The transition can't be successful implemented without your buy-in and assistance. It will be important to incorporate high sensitivity troponin into your algorithms and approach, and to have appropriate decision-making when evaluating patients who are presenting with chest pain and suspected acute coronary syndromes. So we hope to engage you all in a discussion today of the benefits of transitioning to high sensitivity troponin. The objective is really to discuss our anticipated transition to the use of high sensitivity troponins, as the traditional troponins will be going by the wayside. We anticipate that the go live starting date will be September 26th throughout the UHealth health systems. And as a part of that switch, our current educational endeavors are intended to assist the providers and provide awareness to the anticipated changes. We wanted to provide you some information regarding the use of high sensitivity troponins in clinical practice, in particular for the assessment of chest pain and suspected ACS. So with that background, I wanted to welcome Dr. Wagner to give us an overview of the impetus to change to high sensitivity troponin, some of the laboratory perspectives, including how to interpret these new levels and how they compare to our traditional troponin assays, and where do we go from here.
Okay, so as Dr. Alfonso mentioned, we are planning on going live later on this month. I know it came up very quickly. Can't believe it's already September. So some of the objectives for this cover the incorporation and the use of high sensitivity troponin into your general clinical practice, as well as go over some of the algorithms that are typically used when talking about high sensitivity troponin. It's not a one-to-one transition like you're used to for conventional troponin, where you're looking at positive or negative, and we'll go over that a little bit more later. And this is going to apply system-wide, so we're not going to have conventional at some sites and high sensitivity at others. So this will be for the entire system. Yeah, which one is it on? Okay. So just a little bit of background. Our high sensitivity troponin assay that we are using is the high sensitivity troponin T. There are really two flavors of troponins, I's and T's. We'll go over, again, a brief little overview of that here in a minute. But our assay has currently been in use in Europe for around 5 years. It got approved in the US in 2017. And whenever we're talking new clinical assays, new clinical equipment, Europe is usually a few years ahead of us just because of our lovely FDA that likes to hold things up here for a while. So to that end, US hospitals are in various stages of adopting high sensitivity troponin. Not everybody is currently on it. A lot of people are still on conventional troponins. The general overview for high sensitivity testing, these assays tend to be more sensitive, as the name would apply. It's not in the way that some people think. And the real benefit here is that they're more precise at that low end than our standard troponin assays. The key benefits here is that it allows for faster rule out of MIs in the ED setting in chest pain patients and people with general symptoms for that. This in turn leads to more efficient ED throughput. So one of the biggest challenges I think you guys face is that you typically have to observe people for prolonged periods of time. High sensitivity troponin allows you to kind of get that faster rule out for some of those patients you may otherwise have to watch for a very long time. Of course, the trade-off here is because you have that higher sensitivity, higher accuracy, it does tend to be a little less specific. So you're going to catch non-MI related troponin elevations. So you're going to get a lot of those type 2 MIs, any kind of chronic elevation, you're going to see a lot more of. So you're in turn going to trade off a little bit with how many you actually have to work up a little more than you otherwise would. So for this reason, it detects all types of heart injury, including the non-ischemic myocardial injuries and type 2 MIs that you're going to work up a little bit differently. So we're going to try to focus, at least myself, a little more on the ED pathway, and then Dr. Alfonso will probably touch on some of the other aspects of this as well. So this is kind of, again, just an overview, a little bit different way. I think this says almost the same stuff. But like we said, troponin is a very multidisciplinary project. And this one, we really did have to enlist a whole bunch of different disciplines. So emergency medicine is going to be a heavy user of this. You guys are going to be heavy users of this. Pathology is going to be very involved because we're going to have to track metrics. We're going to have to make sure that this is being applied correctly. And then, of course, our IT end of it, there is a lot on the back end in terms of test builds and how we actually get this to order properly. So it's not an easy feat, and most places take a year to roll this stuff out. So hopefully our expedited time frame does not come back to give us a lot of ghosts later on. So in terms of the laboratory aspects of troponin, as everyone in this room knows, I've given this talk other places, so I kind of do a little refresher sometimes. When we talk about troponin, we're not usually talking about just one troponin. So troponin is a complex comprised of troponin C, troponin I, and troponin T. You guys are well aware. Our cardiac specific ones are troponin I and troponin T. Troponin I mostly conserved between our non-cardiac and our cardiac, with the exception being that 31 amino acid N-terminal N that's specific for cardiac troponin. And a similar trend with troponin T, which is an 11 amino acid residue. The assay that you use is usually, whether you're using troponin I or troponin T, is more so influenced by your instrument manufacturer or your instrument vendor. So whoever your main chemistry analyzer is manufactured by will kind of dictate which assay you're running for the most part. Roche, the one that we're running on the UM side, is, or rather, holds the patent on troponin T. So they're the only group that runs troponin T. All of the troponin T assays, therefore, are standardized because they use the same antibodies. Troponin I, on the other hand, is used by all the other vendors. So the troponin I assays don't have the same cutoffs. They don't have the same clinical decision points because they're different manufacturers, different antibodies. They're not comparable. So if we look at the various assays that are available for high sensitivity troponin, troponin I has a very different conserved sequence than troponin T, so they have different targets. So you can see based on the way this sandwich assay is set up. So we have a capture antibody, and then we have a detection antibody. Each of these small shaded areas is what that detection or capture antibody is targeting. And what you can see is each of the manufacturer's antibody targets a different region of that protein. So you really can't compare them. The nice thing about the troponin T assays is that our 4th gen capture site and detection site and our 5th gen or high sensitivity assay capture the same antibody or capture the same region. So in that regard, we have a little bit of flexibility in troponin T, and that we can
work in his case. Lots of other families need due process.
We can apply kind of the same rules that we have we know the performance of it essentially. So when we're looking at contemporary versus high sensitivity troponin, we really have to remember how our troponins are over time. So conventionally, when we have a young, healthy patient population, we have low baseline troponin. I think generally we're looking at about 6% cytosolic free troponin in a healthy individual. And then as you get a little bit older, you have a little bit rise in troponin. And then when we start getting into the myocardial injury and myocardial infarction territory, we start to get a greater rise in troponin. Our contemporary assays wouldn't typically start picking up on troponin until we got out to this elevated phase. The advantageousness of high sensitivity troponin, we can actually detect it at baseline normal levels. And I'll get into the particulars about what exactly that is on the next couple of slides. But the key here is that we can accurately detect it. So when we're talking about sensitivity, we also have to talk about accuracy. Conventional troponin assays could be sensitive, but not particularly accurate. So that doesn't allow us to repeatedly measure something and detect small variances. Because we can detect it down here at the baseline levels, it allows us to have a little bit more diagnostic utility. So what do we actually mean when we're talking about a high sensitivity assay? So here are just a few of the definitions that are the highlights for what high sensitivity assays are. The key for me, or the key takeaway, that if you get nothing else from what makes a high sensitivity assay high sensitivity, you have to be able to detect troponin in at least 50% of your healthy population. So that comes back to what I was talking about earlier. This is not going to be the same as you have a positive troponin or a not positive troponin, because you should be able to get detectable troponin in most of your patients. With high sensitivity troponin T, there is a little bit of discussion whether it actually satisfies that. There are certain patient populations where that number dips into like the 48%. So it's kind of skirting that, is it truly a high sensitivity assay compared to some of the troponin I assays. And the other key difference here is that you need to have a coefficient of variance, or CV, of less than 10% at your 99th percentile. And that is really what makes this different from conventional troponin, is that at your decision point, you have to be able to detect very small changes. And what that allows us to do is actually to also calculate a delta value for a high sensitivity troponin. And that delta value comes into play when it comes to diagnosis and workup for high sensitivity. In general, high sensitivity troponins are going to have sex-specific cutoffs. And for that, as you all know, your male cutoff is going to be higher than your female cutoff, just due to heart size and heart mass. And it is generally recommended that you apply these sex-specific cutoffs in your clinical decision-making. Some of the conventional troponins would set other values. So previous universal definition for MI for a conventional troponin assay was a value of 0.1. That doesn't really correspond to any 99th percentile. The 99th percentile on the previous assay was 0.01, with the limit of detection being 0.03. So you got a lot of numbers with the old one to keep track of, and nobody really quite knew how to use it accurately. So for the high sensitivity assays, we're going to use the 99th percentiles and sex-specific 99th percentiles. For US standards, we also cannot use the limit of detection for this assay as a rule of thumb. So limit of detection, actually, I'll just go to the next one. So some of the key differences between our current assay and our Gen 5, or the high sensitivity, involve how low we can actually go. So as you can see from this nice layout here, our previous assay was 0.01 reportable up to 25 nanograms per mil. The key difference here is we're no longer reporting decimal. Reporting decimals tends to lead to a lot of error, as people can just mentally move over decimal points. So one of the hallmarks of high sensitivity is that they are all reported in whole numbers, so you don't confuse them with the previous ones. And as you can see, the range on these is actually relatively similar. So if you just looked at these and said, okay, our previous one could do 10 to 25,000 nanograms per liter, our new one does 6 to 10,000 nanograms per liter, these are the same assay, right? But that is actually not the case. And we'll go into the particulars on the next slide. But the big notice here is that the optimal precision at 10%. On our previous assay, that was 0.03. So that means the lowest we could accurately tell you had a value was 0.03. Even though it said it was 0.01, the CV at 0.01 was too big for us to say, yes, we can accurately measure this over and over and over again. On the new assays, that number is going to be 6 nanograms per liter. So we can't report anything lower than 6, but we can really confidently tell you it's 6. We could tell the difference between 6 and 7 in this case. So we're going to be looking at that small change now as a guide or an aid to help us make decisions. And then our 99th percentile here that we're going to want to kind of burn into your brain for the next little bit, 14 nanograms per liter for female and 22 nanograms for male. This may be something that we reevaluate later. There are several publications out there that don't like the way Roche established these 99th percentiles and may actually do, if we have enough data, a study to kind of do a patient population specific 99th percentile. That takes a lot of time and a lot of effort on the lab side. So we'll see if we have enough data to back that up or if it's needed. With this whole process, this is probably going to be some give and take. If you guys find this is not working for you, we may go back and make adjustments to this whole algorithm that we're going to get into. But it's going to be fun. Okay, so for performance-wise, if we're looking at our new high-sensitivity assay, which is the Roche assay, the high-sensitivity troponin T, compared to the various troponin I assays that are out there, you can see they all kind of fall in line with another. This is actually not right. Our limited detection is actually 3. But what I want to point out here is that the 99th percentile are quite different for all of these. And this is where this comes into everybody uses different antibodies for their capture and detection. So you have different detection limits. So widely, not comparable. And also you'll notice that typically the troponin I is higher 99th percentile than troponin T. That kind of comes into the fact that you have more troponin I circulating than troponin T. I think it's roughly 10-fold difference usually. And as I said, one of the criteria is that you have a CV of less than 10% at your 99th percentile. And all these assays meet that. Okay, so this is what I was kind of alluding to earlier. If you were just looking at nothing other than the units for this, you could say, okay, our previous assay reported 10 to 25,000. This one reports 6 to 10,000, so they're roughly comparable. But that's actually not accurate. So at the higher values of troponin, so values greater than 100 nanograms per liter, these assays have very good concordance. So you'll get roughly the same number for the really elevated troponin. Below that, it's not comparable, really. So you'll see that at our prior lower limit of detection at 0.03, or basically the lowest number we could accurately report for our conventional troponin, that's going to correspond to 52 nanograms per liter on our new assay. So you can't just visually kind of cue that up. And then 30 nanograms for our 0.01, which is our previous limit of detection. And if you remember what our current 99th current sex-specific 99th percentiles are, they're both below this value. So our decision point is below what our detection limit even was for the other assay. And that's something to kind of keep in mind. You get more sensitivity, but you're also getting greater accuracy in the area that you need it. So this kind of brings us to some of the updates that we have ongoing to universal definition for what myocardial infarction actually is. There was recently, or not so recently, an update. So we're now on the 4th universal definition. I'm going to let Dr. Alfonso go into that more as it's in part of his presentation as well. But the key point here that I wanted to just raise is that based on the 4th universal definition, in order to diagnose or work up an MI, it does require a rise and fall in that troponin value, plus one of the other things shown in this table. So we really need to capture that delta for our troponins, and we don't want to sit on it for 6, 8, 10 hours or multiple days to try to trend that rise and fall. So this kind of brings into the lab, and this is why we needed the multidisciplinary approach. What actually counts as a significant change in a high sensitivity troponin value on a short order? So we're trying to do a truncated rule out scenario where we use a serial measurement over a 3-hour period from admission. The typical ones that people are using are, 3-hour, 6-hour. I don't think anyone's used an 8-hour that I've seen. But you need to know what you consider a significant change in that short time frame. And then you also need to say, okay, what do we want to use in terms of the change? Do we want to use percent change? So percentage of baseline troponin change, or do you want to use an absolute change? And there is a myriad of literature out there on people arguing for either way. Ultimately, we kind of just have to apply some clinical judgment here and use different scenarios that are going to satisfy that. And we are still kind of finalizing what we want to do. But again, keep in mind that as our specificity goes up, our sensitivity, if we want to have a very high specificity for MI, then we're going to sacrifice some stuff in terms of the sensitivity. So there is a trade-off on that. What we actually really needed to do for this whole project and what is taking the bulk of the time is coming up exactly how we want to build this test and how we want to build out the algorithm for working this up. So some of the big questions that we wanted to apply is, are we going to use the 99th percentiles? Other labs use the prior AMI cutoff, which was 0.03 equivalent, or roughly 52 nanograms per liter for troponins as kind of their cut point. It's pretty widely advised to use the 99th percentiles at a sex-specific level. We're still trying to finalize exactly how we want to apply that and in what situations. Because on the backside of that, you also have to keep in mind all of the order sets that use troponin in them. It's a lot. I actually didn't realize how much it was until they started sending us spreadsheets of this, and it's a lot. What kind of algorithm we want to use? Do we want to use a 1 hour, 2 hour, 3 hour? Do we want to use 6 hour? I think what we have settled on for the time being is a 1 and 3 hour serial measurement. So we're going to be looking at our baseline, our 1 hour change, and a 3 hour change. And all of your deltas are going to be referenced back to your 0 time point. So it's not going to be a change from your 1 to 3 hour. It is the change from baseline. And that is mostly to account for time of presentation. So I'm sure you guys all know people are super specific with what time symptoms started and what time they started to feel bad. If somebody presents too early with this and you don't give it enough time, you're not going to see that change in troponin value that you need, and it's just going to complicate things. So some people run this all the way out to 6 hours, and at 6 hours post symptoms, you should definitely see a change, but you also don't necessarily want to hold on to somebody for 6 hours. So we're going to start with a 1 and 3 hour serial measurement and see how that works for us. The other question is, do we want to calculate a delta? Do we want the delta reported in UChart? Everybody was on the same page with this. We are going to calculate the delta for everybody, and we are going to report it in UChart, as well as flagging in UChart. And then one of the other options is some systems get really complicated in their test builds, and they actually trigger timed EKGs along with their troponin collections. We tried to get them to do that. It was a little bit more than our IT team wanted to take on at this time on the short time scale, but we may circle back to that if we find it advantageous to do so. So as I said, what we ended up going with was our 1 and 3 hour serial measurements. So this is just a screen grab of our order set in UChart. In addition to having our baseline troponin with no delta, the ED and anybody working up chest pain symptoms is going to have access to a 0, 1, and 3 hour time delayed panel. There's also a second option here as a 1 and 3 hour add-on. So if you initially order a 0 hour troponin and it comes back abnormal, you want more of them, you can add on that serial measurement that will also calculate the delta. I will say you should be ordering the serial in any case that you have chest pain that you think may be coming to you guys. We really want to discourage, just doing single measurement, single measurement, single measurement. And if you end up having to do this continuation panel, you're going to get some feedback from Epic depending on if it was ordered appropriately or not. So for the actual build out in Epic, what you're going to see, we're going to have all of the troponins trend on the same line for you, so you're not having to look at multiple lines. And it's going to also calculate, as I said, the delta in the chart with you, with flagging on everything, depending on if it's abnormal. In the result review tab, it will actually break out to label it as the 1 hour, but it'll trend all three of them in here as well. That's just a weird little buggy thing that Epic likes to do. Okay, so we're going to get into a little bit of the algorithm, and then I will let the other team go into how they're actually going to work stuff up. But as I just wanted to touch on some of the key values again before we get into this. So again, 99th percentile females, we're going to use 14 as a sex-specific cutoff, and 22 for our males. For the delta values, so what we are going to define as a significant change for these troponins. For a 1 hour change, anything greater than 5 should really get your attention, as that's you could just be catching the start of the upswing for it. And then 3 hour, we want to see a change of 10 or greater to really give us a heads up that something's going on. Anything that should concern you, greater than 99th percentile, I would say or a 1 hour change greater than 5 or a 3 hour change greater than 10. This is predominantly for ED patients. This is going to differ slightly from an inpatient. I don't frequently recommend doing serial measurements on an inpatient just because they're more than likely going to have a baseline elevation if they're admitted, as well as the fact that by the time troponins are elevated, you guys are also probably going to be aware that something is up. If you're waiting 3 hours after they're doing something, I feel like you guys are probably going to be ahead of what our assay can tell you. And you're probably going to get called before the result can call. So this is just one example of said algorithm. It can be a little complicated. This is actually adapted from Mayo's algorithm, but as you can kind of see, it's very methodical on how you can work through this. So if you have a patient that has no evidence of myocardial injury at presentation, meaning they're less than their 99th percentiles, you're going to work them up slightly differently than if you have somebody with a substantial elevated troponin from the start. So the basic idea is less than the 99th percentile. If it's greater than 6 hours since their symptoms onset and they don't have greater than 99th percentile, you can pretty effectively say this is probably not what's going on. Less than 6 hours, then we're going to start to get into our serial measurement algorithm, where we're going to take a 1 hour measurement. And then based on what our delta value is from presentation, we can do either a rapid rule in, hold for further workup, or a rule out. So if 1 hour after presentation, their delta is less than 3, we can pretty safely say with confidence that they're not having an acute MI and go ahead and discharge them. And then same with an intermediate delta or a high delta. So this is basically risk stratification on a rapid order. And again, we'll let Edie and Dr. Alfonso go a little bit more into that. The difference here that we're going to probably apply, and we haven't fully decided on this yet, if a patient presents with myocardial injury, we talked about whether we want to use an absolute delta as a cutoff or a percent delta as a cutoff. Recent literature, people are starting to kind of go a hybrid approach to this. So an absolute delta for the low side and then a percent delta for the high side. So if you have a patient present with a troponin greater than 100, it may not be feasible to look at a change of greater than 10 as a cutoff there, because that's a relatively small percentage of their total troponin load at the moment. So for patients greater than 100, we may actually apply a percent delta rather, but we will have to discuss that a little bit further. Since we are still pre-implementation, we don't know, or we don't have the data for what this is going to do in terms of our impact to diagnoses. This is an example of what other medical centers have seen when switching from a 4th gen to a 5th gen assay like we're about to. Going into their implementation, what they typically saw was they had about 85% of their patients being less than their cutoff, so less than their 99th percentile for the 4th gen, so less than 0.03. Once they switch to high sensitivity, you start to see kind of a stratification between lower than 99th percentile, and then whether they're classified as a type 1 or a type 2 MI or just myocardial injury. So we would expect something similar to happen, where we actually have a greater number of patients presenting in this myocardial injury that we're not seeing currently, in a relatively small difference in our type 1 MI workup. So less than 1% change, or around 1% change of who we're going to catch for a type 1. And then this kind of gray area where we have more type 2s. So it's pretty common to catch more type 2 MIs with a high sensitivity assay. So hopefully we're going to get a lot of good data and see how our patient population falls, because they all are different. And then once we have all of this data, once we start to kind of get comfortable using the high sensitivity approach, one of the things that we have discussed with cardiology and emergency med is potentially going for something like a chest pain accreditation. And that really involves having all of your algorithms down, having all of your data in order, and really being able to meet key metrics. And some of those things are, having a door to needle time. So when your patient walks in versus when they first get drawn, of less than 30 minutes, door to first troponin of 60 minutes, and really having set protocols for how to work up chest pain patients. And that sounds relatively easy, but just that one aspect of door to needle in door to first troponin in 60 minutes can actually be very challenging. This is just a rough timeline of what you need in order to make that time point, actually. So initial evaluation, you get 3 minutes. That's not uncommon for ED. Perform your EKG in the next 3 minutes, read the EKG in the next 3 minutes, place an order for troponin 10 minutes after that. Collect your troponin, send it to the lab, and then process the lab and analyze. It's a pretty short order. If we break this out to just this last component, the lab received to result, you can see why this can actually be a little bit challenging. So I know everybody thinks the lab just kind of spits out a result once we get the thing. There's a little bit more to it than that. So after we get a specimen, first we actually have to process it a little bit. We have to check the sample in. In SunQuest, that is not a super easy task and can be kind of time consuming, but we'll call it 5 minutes. Centrifuge the sample, that's another 4 to 5 minutes. Can't skip that step. We have to centrifuge samples, deliver it to the instrument, have the instrument sample it, and then our assay time on our stat assay is almost 10 minutes. So if we take that perfect step, if we did nothing else but handle that sample and get a result, that's 25 minutes right there. We only have 30 minutes, so that's not a lot of wiggle room. And then any critical notification that we need to do, call that another 10 minutes. So we've taken a big chunk out of our 60-minute window just in sample processing and direct analysis. And that's aside from all the stuff that you guys have to do in terms of looking at the patient, looking at EKGs, ordering tests, and getting it collected. So that is a future direction that we're interested in doing, but it's definitely going to take some work on the front side and logistically. And then that kind of brings us to Dr. Lang. You'll jump in? Okay.
All right, thanks, Dr. Wagner. Unfortunately, Dr. Lang was caught up this morning, so hopefully he'll be able to join us by the end of the talk. But he was going to give us a little bit about the emergency room perspective and what this means for the emergency room in terms of being able to rapidly triage and our chest pain patients in particular. So this is kind of to go through what we've been putting together and working on with Dr. Wagner and Dr. Lang and the rest of the team. The proposed pathway to be used in the emergency room and really for all of our acute chest pain patients that have symptoms. And so as Dr. Wagner kind of highlighted. So if patients have had symptoms more than 2 hours from presentation, call it 3 hours, we should be able to pick up some troponin elevation if they're having a myocardial injury or myocardial infarction, whether it's a type 1 or type 2 myocardial infarction. And so while we're working to rapidly triage them with EKGs, as we all know, should be done pretty soon after the initial presentation, then we should be collecting cardiac troponins and high sensitivity troponins. And so that initial troponins that you can see here will help risk stratify into low, intermediate, and high risk patients. And so with low troponins, so if you have troponins less than 6, detectable high sensitivity is less than 6, and if you have onset of symptoms or more than 3 hours ago, then the other thing you want to look at is the clinical factors, right? And that's what in the emergency room, our colleagues often use what they call the heart score. We'll kind of go through that briefly, just so that we're all aware. But it's the same clinical points and risk stratification tools that similar to what we use, on the cardiology side. And that's one of the aspects that we'll touch on a little bit later. But some of the recent guidelines have supported and have advocated for the use of clinical decision tools and risk stratifying tools for the triage and treatment, of our chest pain patients. And so, the heart score, helps further risk stratify into low and intermediate risks. And so, if patients that have a low heart score have negative troponins, suggests that they're not having active injury or ischemia and could probably be safely discharged with a post-discharge plan in place to follow up with primary care, with further imaging as needed, or cardiology. Depending on what their underlying risks is. So, a heart score 0 to 3, probably, could be safely discharged. If they have higher heart score, have higher risks, then they may want to have for some further cardiac evaluation, but that may be potentially done as an outpatient instead of as an inpatient or in observation. Now, if you have troponins in that above the 99th percentile, gender specific, 14 for women and 22 for men in the troponin T assay that we're going to be using, then you certainly want to get a repeat and to check that delta, and that delta will tell you if there's active rise and fall, whether that's active injury, and again, that will help you make a determination. So if there's not a significant delta and the heart score remains low, then that patient still may be able to be discharged safely from the emergency room. Whereas if the heart score is high, then that requires a fair amount of clinical judgment, in terms of what the disposition is. If you see a significant delta, or if you see a significant elevation in gender-specific values, then really those patients probably should be further evaluated and either admitted or kept in observation, and further imaging and testing, can be decided. What's the clinical driver. So this is just to kind of briefly go through the heart score. This is a risk stratification tool that's widely used in emergency rooms, looking at 5 different factors: history, EKG, age, underlying risk factors, and the initial troponins. And so, nothing that we don't use already, right? Everything's pretty much readily there. Just from based on an HPI, we will know the age, risk factors, and the history of the patient. And then the only 2 other things we need to get is the EKG and the troponins. And so, really, if we follow the algorithms and the chest pain protocols, we should have all this information within an hour of the patient presenting to the emergency room to make a decision, on rapid triage. And what you can see here is, based on the heart score, what are the 6 weeks, estimated risks of MACE. So if you have a heart score between 0 and 3, that shows us that your 6-week risk of major adverse cardiovascular events remains low, around 1% or so. Whereas if you have higher heart scores, between 4 to 6, and if you have a high risk above 7, the 6-week risk of MACE is significantly elevated. And so these patients really require a little bit more evaluation. And again, so in terms of the troponin, we're going to look at not only the baseline values, but the trends, and these are gender specific numbers. So for men, if your scores are below the 99th cutoff, you get 0 points. If you're above the 99th cutoff, but between 22 and 66 in men, and 14 and 42 in women, you get 1 point. And if you're above 66 in men, and 42, which is roughly that the cutoff. You know, if you think about that 52 being equal to 0.03, then that's our traditional cutoff for myocardial injury and infarction, and so you get 2 points for that. So. So this is just kind of going through that. I'll kind of go through this quickly, and it's just kind of what we talked about. If Dr. Lang's able to make it, he could give us a little bit more feedback on terms of the emergency room and what that implies for the emergency room. But briefly, the benefit is that you have more rapid triage, early discharge of patients from the emergency room. The data from Europe, which has been doing this for 10 years now, and some of the early adopters in the US and some of the programs, is that we've seen more rapid triage, less admissions. And so I think that that's a good thing from a hospital system standpoint and from a, workload standpoint for, and particularly for the patients. So what's our perspective as a cardiologist, right? This is the crux of what we're going to be called to do sometimes and evaluate. And so we're going to be detecting myocardial injury at lower levels. And so what we need to understand, as we all do, that myocardial injury is a spectrum. Not every myocardial injury is a myocardial infarction. And that's the key thing for this lecture. And I think you're all aware of it, because we've been dealing with that, for some time, and based on the universal definition of MI, which we'll briefly go through. The key thing is to understand we're going to be detecting lower levels of troponin elevation. So we're going to be detecting lower levels of myocardial injury. Not all of it is acute. Some of it may be chronic, and certainly not all of it is related to a type 1 MI or even a type 2 MI for that matter. So if you think of the bigger in this Venn diagram, the bigger circle is myocardial injury. Acute ischemia is a component of that, and we'll define this in a second. But there's other contributors that can lead to supply-demand mismatch, as we all know, from treating our patients on the wards. And and you can see some of the contributors there: arrhythmias, hypoxemia, anemia, chronic kidney disease, etc. Sepsis, shock patients. Certainly, we could see troponin elevations in a lot of these patients. These terms, troponitis, troponemia, I hate these terms. These should have been, put out of an extinction years ago. We still see them kind of crop up in the EMR sometimes, but they're not specific. They don't really tell us anything. They also, based on some editorials from Dr. Januzzi, probably they devalue they take away some of the risks from the patient. So I think we should no longer encourage using these terms, but we should really talk about myocardial injury. And we'll talk a little bit about that, myocardial injury and infarct. So the fourth definition of myocardial infarction really kind of defined MI into type 1 and type 2 MI. And type 1 MI is what we take care of in the cath lab, when patients come, all the time. So, either it's related to ST elevation, which is a separate discussion. Dr. Dial talked about that earlier in the summer lecture series. So we're not really going to get into ST elevation, but we know that's related to an acute occlusion, an acute occlusive event. For the purposes of this talk, we're really talking about acute coronary syndrome and non-ST elevation MI, which could still be related to plaque erosion, thrombosis, an acute coronary event, and oftentimes, may be an issue with supply, not only demand, but there's a supply issue there. And sometimes type 2 MIs are treated percutaneously and are treated, with revascularization. So it's not, there's also a misconception that type 2 MIs, don't need to go to the cath lab or don't need further revascularization. There are components of type 2 MIs that may need revascularization, but certainly not every type 2 MI needs, further, invasive evaluation or revascularization. And that's because type 2 MIs it's multifaceted pathophysiology. Type 2 MIs could be related to supply-demand mismatch in the setting of underlying atherosclerotic heart disease, as you can see here. And that's, what we typically see in our coronary disease patients, even with chronic coronary disease, that they have a supply issue on top of a demand issue. And we could certainly treat the supply issue with revascularization. But sometimes that's not related to chronic atherosclerotic heart disease and chronic obstructive heart disease. Sometimes that may be related to other dynamic factors, for example, coronary vasospastic disease, spontaneous coronary dissection. There's a whole myriad of coronary pathophysiology, which can lead to supply issues and lead to type 2 myocardial infarctions. The other aspect is demand, demand alone, so increased demand, in the absence of atherosclerosis, as we all know, can lead to troponins. And we're probably going to pick up a lot more of these type 2 demand events, with a higher sensitivity assays. And as Dr. Wagner showed earlier, we're going to pick up about 30% more myocardial injury. If you look at the Mayo Clinic data that he showed on his slide a little earlier, we're going to pick up 30% more elevation troponins because we're picking them up at a lower level. The majority of that is going to be myocardial injury. There's going to be a small component that's going to be type 1 MI, and there's going to be about 4 to 5% more that are going to be type 2 MIs, which is what we're talking about here. So how do we evaluate our patients? And this is kind of going back to the European guidelines from 2020, and it also beckons a slide that Dr. Cohen showed on his presentation of ACS and non-STMI earlier in our sessions. And so I think the clinical setting is going to be key, and the symptoms and the clinical gestalt and the history is going to be key, components of assessing our patients. And so we're going to have to really kind of key in on that, because that's going to be one of the things that's going to help us make a determination what these troponin elevations really mean. Okay, the timing is also going to be important. When was the last episode of chest pain? So as we were alluding to, if the chest pain occurs recently, within 2 hours, we still may be within that window of uncertainty where we may not pick up a troponin elevation. But certainly if the patient's 2 or 3 hours beyond their episode of chest pain, if there was some degree of myocardial injury, which was related to either type 1 or type 2 MI, we should be able to pick that up. EKG is always key and essential in what we do. So markers of ischemia on EKG are also going to be markers that are going to help define whether this is ischemic injury or non-ischemic injury in these patients that have troponin elevation. And so, and finally, for patients that are, excuse me, that are uncertain, we're going to have an algorithm and an approach to refer for further imaging, further verification if there is injury or if there's at-risk features. And we still haven't honed down on what type of imaging. We'll briefly talk about the 2021 chest pain guidelines, which kind of goes into that, but we really won't get into that in depth for the purposes of the lecture today. We're also deciding within our own internal system, over the next month and year, what's going to be the best work through, for these patients. Do we use functional imaging? Do we use CT imaging? The chest pain guidelines, that were put out last year, certainly advocate for both, and the utility of both for our higher risk patients. And so based on the clinical symptoms, the EKG and the troponins, not only the baseline, but the change in troponins, we could really adequately rule out patients for injury, and the differential diagnosis is going to change. If for patients that have positive troponins, we may observe those. It may be unstable angina, maybe, if their troponins are elevated, now, we're talking about injury and infarct. And for significantly elevated troponins with dynamic EKG changes, certainly we're gonna treat these patients differently. So, with that, in 2021, there was a multidisciplinary, multi-joint efforts and working on the chest pain guidelines. And I think that, again, we won't talk about this in depth, but for those of you that were fortunate to go to the Florida ACC a couple of weeks ago, Dr. Gulati did go through some of the, what went into developing the guidelines and kind of went into these a little bit more in depth. I think for the purposes of this lecture, what we wanted to highlight is the high sensitivity troponin is one of these things that has been advocated in the guidelines. And so it's now a class 1 indication to use high sensitivity troponin as your preferred biomarker for patients that present with chest pain. We want to use biomarkers and troponins, and really high sensitivity is the preferred marker, because we're going to be detecting more of these early injuries and be able to risk stratify our patients better. Another thing to point out is that CKs and MBs are actually considered now of no benefit. And so within our own system, for the cardiac profile, just a point to make is that the CKs and MBs are going to go away, and we're not going to, cardiac profile is no longer going to include CPK and MB as a part of the cardiac profile. I always thought that there was a value for them, because looking at the trends and the dynamics, particularly for diagnosing recurrent MI, but overall in the grand scheme of things, with the high sensitivity troponins, it probably doesn't add on a whole lot more value than so they're going to be going away. So in terms of evaluating chest pain, I think that this is for the purpose of this talk, the high sensitivity troponins is what I wanted to focus on. Another aspect of chest pain is that we really want to go away from the term atypical chest pain. One of the key recommendations from the guidelines was to no longer call it atypical because again it devalues this chest pain. We want to classify it as non-cardiac, possibly cardiac, or cardiac type of chest pain. Okay, and also they advocated for the use of clinical decision pathways as we discussed and structured risk assessment tools, which we'll briefly get into a little bit. So. Won't belabor this too much, the slide too much, because we kind of already talked about the benefits of trending troponins and the timing from the symptom onset. So if you present very early sampling within 2 hours, you may not pick up this early troponin. And that's why it's important to understand when symptom onset really happens. As Dr. Wagner alluded to, many of our patients can't really precisely tell us when symptom onset happens. And so, the dynamic serial troponins really are useful here because by 3 hours we could really pick up any significant elevation, and perhaps even by 1 hour, we should be able to pick up some of those early elevations and rises and falls. So at the back end, also very late sampling, we may also see some elevation, and if we have a declining delta, that may also be a marker that we're on this back end, rather than on this front end of the event. So what you see here is two curves, right? You see this solid curve with rise and fall, and that's what we see classically in acute myocardial injury versus a more flat dotted line here for patients with chronic myocardial injury, which is important to understand because many of our patients with heart disease, structural heart disease, not necessarily acute ischemic heart disease, may be coming and may be evaluated, in the emergency room in the hospital. So as we know for our typical troponins, we've talked about previously, flat troponins are usually more consistent with chronic disease. Rise and fall is more consistent with acute disease. And we see that with the high sensitivity troponins as well. But we're going to be detecting them at lower levels. So this is just to highlight, again, some of the data from a decade ago, looking at the serial changes in troponins, and which allow for early diagnosis of myocardial infarction. This is looking at the receiver operator curve for using high sensitivities compared to contemporary assays and other markers such as MB, CK, and myoglobin. And you can see that the high sensitivity troponins really outperformed all the other biomarkers. They had the highest area under the curve, and using levels obtained at 3 hours really have a sensitivity of 98% with negative predictive value of 99% to rule out myocardial injury and infarction. And so if you combine the serial changes, you have a really good positive predictive value, close to 96%. So this is really the pathway that that's been proposed. We're incorporating something relatively similar. And so if you have elevated cardiac troponin values, which are above the 99th percentile, you want to look at if there's a rise and fall or if the levels are stable. So if the levels are stable, that tells you that this is more likely chronic myocardial injury for whatever cause, whether it's structural heart disease, CKD, valvular heart disease, infiltrative heart disease, etc. If there is a rise and fall, then you really have to determine, is this related to acute ischemia or is this injury without acute ischemia? And we base that on the other factors, the clinical history and the EKG findings. With acute myocardial ischemia, then you really if there is acute evidence of acute ischemia, then we call this a myocardial infarction, and then we have to determine, is it a type 1 MI related to atherosclerosis and acute thrombosis, or is this a type 2 MI related to oxygen supply imbalance? And some of this could still be supply issues, but again, that helps further the differentiation. So this is the algorithm that we've put together and summarized, from some of the other looking at some of the other sites that have gone live within the past few years in the US, and also some of the data here. So similar to what we do already with our acute chest pain patients, that have an EKG within 10 minutes, and if you have ST elevations, certainly that they are activated via the STEMI protocol, and we evaluate those patients emergently, if they need to go to the cath lab. If they don't have ST elevations, but then at that point, we get the high sensitivity troponins, and hopefully in the near future we'll be able to get those, within time periods that, like Dr. Wagner, mentioned, to go towards chest pain accreditation, and really just better care overall, honestly. And so if we see those initial troponins, and here we have the levels, greater than 52, which really, is our traditional levels of identifying MI. We are going to be reporting the gender-specific levels, just to be aware of that as well too. But if the levels are elevated, you could already diagnose myocardial injury, and then we'll differentiate into non-ischemic, type 2, or non-STMI, etc. If the levels aren't elevated, then you would do a 1 hour and a 3 hour. And so, as you can see here, if there's a dynamic change at 1 and 3 hours, greater than 5 and greater than 10 respectively, then we could again diagnose myocardial injury and consider further testing, and whether invasive or non-invasive, based on other patient factors. So it's important to understand, the positive predictive value for myocardial infarction. But as you can see here, the levels of troponin elevation and concentration are on the y-axis, and you can see different types of injury here. So the 99th percentile sits about 14 to 22, our gender-specific cutoffs. And like you see below those, you may still have some mild detectable elevation in patients with stable heart disease, stable angina, et cetera. The levels, may also, be predictive of the amount of myocardial injury, but you see there's a wide spread. So you can't just use the levels as a cutoff, to define whether this is MI, or whether this is myocarditis, for example, or other causes for troponin elevation. So in terms of, how do we differentiate? Well, I think that if you have evidence of myocardial injury, you want to, the second question, is there clinical evidence of myocardial ischemia? So, and that's based on clinical factors, that's based on EKG, like we discussed. If there's no myocardial ischemia, then really we're looking at non-ischemic myocardial injury. And actually, as of 2021, there's a new ICD-10 code for non-ischemic myocardial injury, which I listed here. And it's important because that actually, from what I understand, triggers a CC or MCC, which helps the hospital capture the true comorbidities for these patients, and also has some implications in terms of reimbursement for the hospitals, as well. And because it still captures some of the complexity of our patients, even though it's not a true infarct. They may have non-ischemic, they have myocardial injury, and so that captures some of that complexities. And then whether it's a type 2 or type 1 MI, we'll be basing, treating those patients based on our current protocols. How am I doing in time? All right. So we should be wrapping up. So if you have non-ischemic injury, I think that the other important thing is to differentiate whether this is acute or chronic injury. You can see some of the causes there that we all know. Acute injury being defined by rise and falls. Chronic, there's no rise and fall, and there's flat troponins, and you can see the whole myriad of factors that can lead to either both of those conditions, which we won't get into in depth. So about 30, 40 years ago, Dr. Braunwald developed a classification system for unstable angina. And you can see here that it was basically based on clinical circumstances, where it was secondary to extra cardiac conditions, post-op, for example, or whether it was a primary unstable angina, or whether it was post-infarct angina. And he classified it based on severity. More recently, he wrote opinion paper which called for is it time for a requiem for unstable angina, or does it even exist? Well, it could be that more of these episodes that we used to call unstable angina are really small, type 2 MIs, or so we may be picking up more of these. But we do know that there is still some patients that truly present with unstable angina, particularly if in the absence of troponin. So it may not be time for a requiem, but we're certainly going to be picking up more patients that have subtle markers of myocardial injury. So this is in the interest of time. We'll move past this. So I think that the benefit, really of the high sensitivity troponin is going to help us risk stratify our patients with ACS into low, intermediate, and intermediate risk, as well as high risk, a little bit easier. So what does that imply for our systems? Well, if you look at the European data, some of the concern was that, is that going to lead to more patients going to the cath lab, more coronary angiography, more cardiac stress testing? And what we saw was actually the opposite. There wasn't any increase in stress testing or coronary angiography in Europe when they deployed high sensitivity troponins. There was the benefit, however, there was an earlier discharge, and so there was better risk stratification with the use of high sensitivity troponins. What you see here is that at the time of coronary angiography, findings before and after high sensitivity troponin implementation in Europe, phase A is before, phase B is after, and you can see for those patients that went to the cath lab, it was essentially the same. So it didn't really change in terms of which patients, and what we found at the time of cath when these patients did go to the cath lab. So what about in the U.S.? What's been the early experience in the U.S.? Have we seen an increase, in imaging in time to the cath lab? Has medical legal concerns, in the U.S. may be different than in Europe. So has that, increased, further downstream testing? Well, what you see here is the Boston experience over about 5 hospitals. 7,500 patients. Their early experience just published last year, and so there is some more upfront testing, but that upfront testing really revolves around the troponins and EKG testing. Downstream, actually, what you see is some decrease in the use of stress testing and imaging, anatomical imaging with CT. There's a slight decrease in terms of overall cardiac revascularization, but that's it just crossed the baseline there. So I wanted to kind of summarize by some of the points on high sensitivity troponins. So basically, the high sensitivity troponins should be the preferred biomarker. It allows for expedited evaluation of our patients. The assays are the numbers are assay specific, so you have to know what assay you're using. It's not they can't be translated across systems and across assays. And the thresholds, you have to have thresholds for the diagnosis of myocardial infarction. There are sex-specific thresholds, as we discussed, and so that's important to understand as well. One single value can rule out an MI in patients if they present late enough, and so it's sensitive but not specific. The patterning changes are helpful, and you also need to account for the other clinical data. Final thing is that interpretation should be done in a clinical context and will always be necessary. So with that, I wanted to kind of recognize the rest of the team that led to the implementation of this, which is going to go live on September 26th again. There's going to be some further information over the course of the month to remind everybody, and some of these resources will be available online, hopefully in the near future for further reference in the future. So thank you all. And I think if we have some time for questions, we could answer any questions that anybody may have. Yeah, let's see them. Okay. Yeah, hey, Jerry.
Especially for thank you for the presentation. It's great. Yeah. But for the hospitals, are we gonna divulge this information to the hospitals, because I do see a lot of hospitals coming.
Yeah, no, absolutely. So I think that, so we haven't gotten them, so we are going to be reaching out to the hospital medicine group, to kind of incorporate them. I think the process, we've primarily worked from the upstream process with the emergency department for the early identification of chest pain patients. I think that the process, as Dr. Wagner alluded to, in hospital may be different. The troponin, we haven't changed it, so it may be different in hospital. So absolutely, I think that, if we're going to have a different process for inpatients, that's one thing. The second thing is in terms of the interpretation, and how to use these tools. So part of it, getting everybody comfortable with it is education, and that's part of why we're doing these lectures, the grand rounds. We're going to have ongoing series, to how to use that. And I think that's what we're going to have to educate everybody, in the hospital and in our systems, how, what do these troponins really mean? The key thing is that an elevated troponin doesn't mean myocardial injury. Doesn't mean myocardial infarction. It means, some degree of myocardial injury for whatever cause, and we could certainly identify that. So interestingly, in terms of consults, if you look at, some of the data in both Europe and the US, it doesn't necessarily increase the amount of cardiology consults that were generated, in these hospital systems. Having said that, I think that we have to get the education and the efforts out, so that everybody gets comfortable with the use of high sensitivity troponins. And it is a work in progress. It is, a learning process. So we're going to, hopefully continue to do these, as the need arises. So. All right. Unless there's any other questions, we'll adjourn for the day, and more to come in the near future.